Okay. Hello, everybody. Welcome. Um, I am Margaret Crone, the Director of the Maryland Physician Health Programs, or MPHP. We are part of the Center for Healthy Maryland, the Maryland State Medical Society Foundation. We are so happy to have all of you here. This is our first annual symposium on physician health, and we're very, very excited. Let me tell you a little bit about us. The Center for Healthy Maryland was established in 1976 as a 501c3 corporation to support the charitable, educational, and scientific purposes and functions of MedChi, which is the Medical Society of Maryland. For those of you who don't know us, MPHP's mission, very much like other PHPs in other states, is to provide compassionate, high-quality assistance to physicians and other healthcare professionals dealing with potentially impairing conditions in a compassionate, supportive setting while protecting both the confidentiality of the participant, but most importantly, the safety of the public and patients. Last year, to mark our 45th anniversary of the founding of the Maryland Physician Health Program, we established a lecture series, Lemons to Lemonade, Harnessing Our Strength in Difficult Times. Our goal with the series is to support our provider community by ensuring that they know who we are, MPHP, what we do, and to provide information about health and wellness. We've presented 7 lectures over the past year and a half, with plans for 5 lectures in 2025. As part of our series, again, we bring you today our first annual Physician Health Symposium. Today, you will hear from 2 excellent speakers about the state of physician health, how events of the past several years have impacted it, and how physician health programs support and assist. We will also hear from a panel of 4 former PHP participants who will discuss their lived experiences in this program. So get ready for some very, very powerful stuff here today. Just want to go over a couple of housekeeping details, and we'll repeat this because I know that as people are coming in, we want to keep everyone up to speed with this. But we very much want our audience to join in the discussion. So please put comments and questions, feedback in the chat so that at the end of each of the lectures and the panel discussion, that I can go into that chat and present those questions to the speakers, feedback, all of that. So again, we really want you to be involved, so please let us know. This is going to be a long morning, so we have templated into this 2 10-minute breaks after each of our 2 lectures. We'll cue you when those breaks are over and let you know that we're getting ready for our next speaker. CMEs, this is important, I know, for many of you. So all of those who we see have attended the symposium will be sent a link to take the CME questionnaires. There'll be 3 separate questionnaires, 1 for each presentation today. Please answer only the questionnaires for the presentations you attend. If you attend all 3, that's great, but if you have to bow out or come back or something like that, please take the questionnaires for the lectures or the panel discussion that you've attended. Certificates will be sent out to you within 10 business days of us receiving your completed questionnaires. As always, we value your feedback and encourage you to tell us how we can improve things and what kind of lectures you would like to see in the future. I do want to say that this is the first time that we are using this format, this webinar format, to present our symposium. So apologies to begin with if there are any waits or glitches, but I know you guys are all wonderful and patient, and we will nonetheless present a really valuable and wonderful program today. Please take note, I know that you saw in the waiting room the slides of our very generous sponsors. We're so appreciative of their support. And we're so appreciative of your support. Obviously, we cannot do this without this very dedicated village. Now, what I'd like to do is turn this over to one of MPHP's really terrific staff, Mike Lafrio. He is going to introduce himself, and he will be introducing also our first speaker. So get ready.
Good morning. I'm Mike Lafrio. I'm the Director of Operations for the programs here. I've been around for 36 years doing this work, which has been the best experience of my career. It is my pleasure now to introduce our first speaker, Dr. Mark Albanese. He is the Medical Director of the Massachusetts Physician Health Services. He is also on the Board of Directors of the Federation of State Physician Health Programs, serving as the Northeast Region Director. Dr. Albanese is a graduate of Harvard College and Weill Cornell Medical College of Cornell University and has more than 30 years of experience as a psychiatrist specializing in addictions. Most recently, Dr. Albanese was Director of Outpatient Psychiatry and Medical Director for Addictions at Cambridge Health Alliance. He is an assistant professor of psychiatry at Harvard Medical School and is board certified in both psychiatry and addiction psychiatry. I give you Dr. Mark Albanese.
Good morning. I guess this is where I share my screen. There we go. Hopefully everybody sees that. And all right. Is that it? Can people see the slide? I don't know how I would know that you could or not since I don't see anybody, but in any case, let me jump in. So thanks for that introduction, Mike. I really appreciate your words. I'm glad you kept it brief. I've entitled my presentation "An Evolving View of Physician Unwellness and Wellness." Recently I get a lot of invitations to speak to various groups. We have a lot of. I'm here in Massachusetts. We have a number of academic medical centers, and again, frequently get invited to talk to various groups. So recently got an invitation from the DIO of one of those medical centers. The DIO, for those of you who don't know, is the person basically who oversees. I believe that the acronym stands for Designated Institutional Official, and that's the person who oversees all of the training programs. So he was inviting me to this meeting of all of the program directors for the various training programs, and whenever I get one of these invitations, I try to connect with the inviter before I do the presentation, because I really am interested in what it is they want me to talk about, because the issue of physician health programs, physician health, it's a pretty big topic, and usually people have certain specific things in mind. And so I got together with the DIO, and I said, so what do you want the program directors to hear from me? And one of the points he said is, you need to tell them that PHS isn't just for alcohol. And that's really what I want to talk about. Certainly, physicians get referred to the physician health programs across the United States. I happen to be medical director of the one here in Massachusetts, Physician Health Services, or PHS. Physicians get referred to us for substance use disorders, alcohol, that being the primary substance of abuse among physicians, as it is in the general population. But the thing I really want to emphasize is how the referrals have changed really in the last 40 or 50 years. And the change has really accelerated with the traumatic event that we've all lived through, namely the pandemic. And so while I've been in the position of medical director of PHS for about 3.5 years, I've been fortunate to be a member of one of the standing committees of the Physician Health Services, the Clinical Advisory Committee, since the 90s. So have been lucky enough to have a kind of a front row seat watching this evolution in who gets referred to a physician health program and how physician health programs have evolved to meet the varying needs, and how we will need to continue to evolve. So that's a little bit of background, a little more background. So again, PHS, the Physician Health Services here in Massachusetts, is one of the 50-ish physician health programs across the country and Canada, across the US and Canada. And I've been invited by my colleagues in the Maryland Physician Health Program to be a part of this, this conference this morning. So I think this timeline will hopefully put a little flesh on the skeleton I just gave about how PHPs are evolving. So our program, so PHS was started in the 1970s by basically a group of concerned physician members of the Massachusetts Medical Society. And it was started as a committee of MMS. And it was not politically correctly named the Impaired Physicians Committee. And it was really about physicians helping other physicians who clearly had a problem with alcohol use disorder. And one of the tools that was developed in order to help physicians who were referred to this committee was the creation of a substance use monitoring contract. And I'm not going into a lot of the details about how kind of the day-to-day nuts and bolts of how a physician health program operates. I know that recently one of our members of the Federation of State Physician Health Programs, Dr. Lisa Merlot, gave a pretty incredibly comprehensive description of PHPs and how they operate. And I'm certainly happy to expand on anything that I reference toward the end of my presentation when we have time for questions. But in any case, of the people who get referred to of the physicians who get referred to a physician health program, a certain number of those physicians continue in a relationship with the physician health program. In that relationship is a monitoring contract. And so the first one developed at PHS, as I'm sure across the country, was this substance use contract. And basically, the physician agreed to treatment, to go to meetings, and the program provides support, toxicology, that kind of thing. So 1970s, the Impaired Physicians Committee largely, actually probably solely alcohol, maybe some other substances, but that's pretty much the extent. In the about 31 years ago, it was 93, the committee was incorporated as a 501c3 fully owned subsidiary of the Massachusetts Medical Society. And this is around the time that I was appointed to the Clinical Advisory Committee. And what we started to see, again, overwhelmingly referrals were physicians with substance use disorders. And I should add that by physicians, I'm talking about fully licensed physicians, physicians in training, both MDs and DOs, and also students. So we have 4 medical schools in Massachusetts, and we are available to all 4 medical schools. We don't have any DO schools. If we did, then they also would be able to access the physician health services. So while PHS was still addressing the needs of folks with SUD, increasingly what was clear was the acknowledgement of the fact that so many of the physicians who were presenting to us had co-occurring disorders. And now I'm thinking mainly about behavioral health disorders, but other issues as well, and we'll talk a little bit about that too. And I should say that what we were seeing at PHS really reflected what was going on really in the general population and society in general. In the early 90s, we starting to the literature started seeing publications that really related to this issue of co-occurring disorders. Some in addiction psychiatrists really have been following the addictions literature for 30 plus years. And what you started to see was epidemiological studies, the biggest one of which is the National Comorbidity Survey of the early 90s, which was replicated 10 years later. And what that really underscored to the field was the high co-occurrence of mental health issues and substance use issues. And so no surprise, that becomes really increasingly evident in the population of physicians who get referred to PHS and I'm sure to other physician health programs. So developed the behavioral health contract to help monitor those physicians. And not surprisingly, we have physicians, in fact, the biggest cohort of physicians that we monitor, and it's about 100 physicians in total that we are in a monitoring relationship with. The single biggest group are people who are on a combined substance use and behavioral health contract. And as I said, I'm happy to talk more about the contracts later. So again, kind of the timeline moves on. We hit the early 2000s, and now what we start to see more of are physicians being referred for problematic behavior in the workplace, and not really sure what all is going on. Could it be substance driven? Could it be mental health driven? Could it be both? Could it be neither of the above? And so people get referred, started getting referred to us, and for a comprehensive evaluation, and what we started to find was that people basically didn't necessarily have substance use disorder, and didn't have any diagnosable kind of major behavioral health disorder. But their interpersonal style, their kind of defensive, defensive style, psychological defenses were such that they had real shortcomings in the workplace in terms of being able to negotiate relationships, and primarily with colleagues. They might be fine with patients, but they really were problematic with physician colleagues, nurses, other allied health professionals. And so these were not people who really fit easy or didn't fit at all really into a substance use contract or even a behavioral health contract, which is mainly for people who have major depression, maybe bipolar disorder, post-traumatic stress disorder, perhaps one of the primary psychotic disorders. But these were people where there wasn't anything diagnosable like that. But as I said, more of an interpersonal kind of psychological style that just didn't fit well in the workplace without some attention. So my predecessor, Dr. Edelman, developed the acronym I have here is OHMA and OMA, Occupational Health Management Agreement. And really the key aspect to that agreement is that we provide coaching, a professional coach, to work with the physician and the workplace to teach the physician skills for better, kind of being a better citizen in the workplace. So that's just a little bit of where we were at in 2020, and then COVID happened, and I think that much of what we're seeing now is, again, substance use, mental health issues, problematic behavior, but now really having been influenced by this universally traumatic experience. And in fact, the proportion of referrals that we get now for both behavioral health and problematic behavior have increased relative to the referrals for substance use. So, what do we encounter in this in this kind of post-COVID healthcare environment? And I'm sure all of you are living in this environment, so I'm not saying anything here that isn't going to sound very familiar to everybody else on this webinar. So isolation and loneliness, and it's interesting because when we went into the cave in 2020, we went into this cave of isolation and loneliness. I don't think we've really emerged from that. And so, we continue to encounter this, and it's something we really need to come to terms with societally as well as among healthcare professionals. Feeling undervalued within healthcare. I think, again, one of the reasons why we're getting these increase in referrals for problematic behavior is there's basically a lower frustration tolerance for all of those things that were already frustrating before COVID, right? I mean, the electronic medical record is on top of everybody's list of things I wish I didn't need to deal with. The prior authorizations, PAs, all that was already bothersome. Put us through this traumatic experience of a pandemic, and we come out even more frustrated, less patience for the glitches that come up administratively for all of us, day to day. And then, we lose sight, because of all of this, of the mission. And that's another complaint that we as healthcare providers have, which is it's hard to see, what's our mission? It's kind of like you're cutting through this jungle of other things to try to, get to the patient, get to what, drew all of us to healthcare. And this is this quote, I think I'm quoting Yoda directly. The dark side clouds everything, impossible to see the future is. And so, we're so in the midst of the trees that it's hard to see, that mission, which is kind of the bigger view, the forest. And I think a lot of people really despair. It's a tough time to keep that hopefulness alive. We've also lost a lot of people, not just physicians, nurses and other healthcare professionals. And when we lose somebody, we're usually losing an experienced person, somebody who's just, basically said, listen, I've done my thing. I just can't do this anymore. And it's an expensive proposition. If you run a healthcare system, you know how expensive it is to lose people and then have to, if you can hire, and that's a challenge, hire somebody, get them oriented, get them on track. So that's part of this, post-COVID environment. And it's we have increasing diversity within healthcare, which is really a wonderful thing. And the diversity includes, I'd say generational diversity. So people coming out of college into medical school, out of medical school into training, have their own ideas and worldview that are not necessarily those of the worldview of those of us who've been in practice for a while. They're not necessarily sure that they kind of want to do it the way we have done it. In fact, they're pretty sure they don't, from the ones that I encounter. So there's kind of dealing with that, kind of different worldviews entering the profession, and those people also being influenced, because they were in medical school, for example, at the time of the pandemic. So this is really kind of what we're the environment that we're living in. So, it's no surprise that, a program entitled the Physician Health Program is really encountering a much more diverse set of issues. In these issues kind of coming to our attention over the course, as I said, of 30 or 40 years, and now being accelerated thanks to the pandemic. This is just a schematic looking at what the scope of referrals is like to our physician health program. And by the way, I keep tweaking this. I'm not great with those tweakings, but in any case, I realize I need to. These are not discrete bubbles. There should be some overlap, kind of like a number of little Venn diagrams here. And in fact, it's that very complexity of the presentations, where it's not just somebody has a problem with alcohol, but somebody has a problem with alcohol and bipolar disorder. Somebody has a problem also with burnout, which is exacerbating inability to really take adequate care of herself or himself. So really, this schematic doesn't do justice to, I think it captures the scope of who comes, but to capture the complexity, there needs to be the overlap of these bubbles. But in any case, just looking at these discrete bubbles. So yes, we still get the referrals for substance use. As I mentioned, we still get referrals for mental health issues. And in fact, when we looked at our data, the last couple of quarters, the referrals for mental health issues have been ahead of the referrals for substance use disorders. And then there were referrals for problematic workplace behavior, at the bottom of the schematic. And I have it next to occupational stress and burnout for a reason, which is that I think that those behaviors, while they may have existed prior to COVID, have really been accelerated and escalated as a result of the fact that everybody's burned out. There's not tolerance for misbehavior, but there's more likely to be misbehavior because everybody's feeling under pressure. And then, we get referrals for non-addiction, non-behavioral health health issues, neurocognitive issues. You know, somebody, a chief of service calls and says, hey, listen, we have a physician who seems to not be as cognitively sharp as she or he was. And so they'll refer the physician to us. And incidentally, it will do an evaluation. And it's been really quite interesting to see. Indeed, a number of these physicians have started to what they're manifesting, and what neuropsychology testing confirms is that they're experiencing really the beginning of cognitive decline. But some of these referrals for cognitive issues have ended up being undertreated depression, or sequelae of periods of intense drinking, which wasn't on anybody's radar screen. The physician wasn't sent to us because anybody thought they had a problem with alcohol. But it manifests in different ways neurocognitively. You take the alcohol away, and the physician does no longer has the cognitive challenges. But by the way, the other layer of complexity in terms of referrals is, you may identify an alcohol use disorder and get somebody under contract. They improve, they get into really good recovery, but then something that manifests is that, hey, you know what, there was a defensive kind of interpersonal style that was being covered up a bit by the alcohol, and now we're kind of shifting gears to try to focus on that issue, because now all of a sudden that's becoming a problem in the workplace. So, it's not only the population of people referred to us that's evolving, but with any individual physician, the story, the picture might evolve, and you have to kind of stay on top of all that. I mentioned neurocognition, other medical conditions that we've kind of picked up during the evaluation process with us. Sleep disorders, for example, sleep in general. I mean, we as a society are not getting enough sleep. And I should, one thing I would say is that I somewhat provocatively at a FSPHP board meeting one time announced somewhat publicly that I'd had the revelation that I had in fact been at work impaired, and it had nothing to do with alcohol, nothing to do with drugs, nothing to do with a mental illness, but it had everything to do with the fact that I was I was at like hour 24 of a 28-hour on-call shift. That is a problem. I'll leave that be for now. That's beyond the scope of what I'm going to talk about. It's a real problem. Physicians, because of the safety sensitivity of our work, or for the work of nurses, other healthcare providers, there's a lot of attention paid to impairment, as there is with occupations like being airline pilots. I could tell you there's no airline pilot that would be at hour 24 of a 28-hour shift, because they're not allowed to do that. In any case, something else for us to think about as a profession. So certainly the health issues of healthcare providers came to the attention really even prior to the pandemic, but certainly in the midst of the pandemic, came to the attention of the U.S. Surgeon General. The Surgeon General convened a work group to take a really deep dive into the issue of burnout, and they published this task force report entitled "Addressing Health Worker Burnout: The U.S. Surgeon General's Advisory on Building a Thriving Health Workforce." And this is a this is definitely worth the read. You know, I should probably provide a link in my presentation to this, but I guarantee you, if you Google U.S. Surgeon General and burnout, this is the first thing that's going to pop up, and you can click on the link there. And so this was all about kind of describing, describing what the issues are, and I've kind of gone over that already. And then, what from the Surgeon General task forces, perspective, we can do as a society to address this issue of burnout and healthcare provider health. And a couple of key points, and you can tell my favorite point from this, whatever it is, 40-something page report, is this quote where the Surgeon General says, we must shift burnout from a me problem to a we problem. And if you think back to, when we first started talking about burnout, and we really wasn't that long ago that we put a word to what it was we were all feeling. It was pre-COVID, but, it's not too much before that. It seemed like every solution that came out of kind of the healthcare community was, giving us as individual providers resources and tools, frankly, that we didn't ask for, but which were seen as potential resources for us. So, here's the number for the employee assistance program. Here's a refrigerator magnet with the EAP phone number and contact information. I must have gotten 2 or 3 of those. Mindfulness. We're going to start offering discounts for mindfulness classes, yoga, all really good stuff. But it was all about, here, physician, here, individual provider, here's something that you can do, we'll defray the cost or whatever. And I think a lot of people, took advantage of that. But there's a limit to what we can do as individually in terms of addressing our own burnout. As one of my colleagues said, at one of our standing committees here at PHS is a general medical education committee. And so it's comprised of these DIOs that I mentioned and a number of program directors from across the state. And one of them, I must have mentioned I was going to be doing some kind of presentation at one of the bigger healthcare systems. And one of the participants at our GME meeting said, please tell them, I don't need the EAP number again. I'm already meditating and doing yoga. What I need is time to get my work done. And I think we all have, we've all felt that way at times, probably quite frequently. In fact, maybe as recently as today, right? So the Surgeon General, is, this task force says, hey, listen, you know what? This isn't a simple fix to address burnout. In fact, we need to address this at all levels of society. And indeed, the task force report has about 34 and a half, I counted them, 34 and a half pages of recommendations to us at all levels of society, starting with federal, state, local, and tribal governments. And I'm not going to go through all of that, but a couple of points I'd make. One is that, again, complex problem needs a complex series of solutions. And, we as a society, I think, need to commit ourselves to taking this on at all levels. And I'll talk a little bit about that at the end, but not in great detail. The two points I kind of want to underscore are, first of all, that, again, there were like 34 and a half pages of recommendations. Only 1.5 pages were directed to us as individual healthcare providers. So there are some recommendations that are geared toward us individually, and I'll go over those because it's worth looking at those. But the other point I'd make is when you look at a number of these recommendations made by the Surgeon General, not just the ones geared toward individual providers, but the ones geared toward all levels of society and the healthcare system, a lot of them are underscoring the importance of connection in society, connection among healthcare providers, so in connection between healthcare providers and the communities they serve. And so, another point I make when I'm talking to my colleagues is we need to be less isolated, right? And that's one of the sequelae of what we've been through is further isolation that we haven't totally overcome. So let's look at those recommendations made specifically to healthcare workers. And again, this report isn't just about physicians. It's about all healthcare workers, really, literally everybody who works in the healthcare industry, the people who run the facilities, the nurses, the pharmacists, everybody. And so this is the 5 discrete recommendations, take up 1.5 pages of this report. And again, and I've highlighted some of the words because they're words that suggest the importance of connection, working together, collaborating. And again, this report is really full of words like that, underscoring, again, the importance of not working in isolation. So bullet number 1, I don't think anybody would disagree with this. Being connected enough to your colleagues, and maybe it's by Zoom or some combination of Zoom and in person, being connected enough that we can recognize the distress and burnout in them, and that they can see it in us. We might not have the insight into how maybe we're acting differently, and we're not even aware of the level of how fatigued and burned out we're feeling. And we have to create an environment where we give each other permission to put a label on what we're observing, right? Hey, I know you. We've worked together for 20 years. You're just not yourself. What's going on? So that kind of recognition, and then staying connected to people, particularly, once you kind of have identified that somebody's having a tough time, checking in. And again, we all, we don't have a ton of time, but you'll see I have one of my own examples of kind of a text connection that I made with a colleague that actually didn't take me that long. So again, staying connected, and if we're looking for help, having overcoming that barrier of not wanting to admit that we need help. Another point that the Surgeon General's group made was, we all have moments of joy during the day, during the week. We really have to pay attention to those moments, enjoy those moments, and share those moments with colleagues, because then everybody wins. And, I sometimes fear that when I say this, the audience are like rolling their eyes saying, what is this guy talking about? It's all misery in the workplace. And I've spoken to my colleagues. I do the work myself. I'm very aware of every day there's some moment that, that makes me say, yeah, this is why I'm doing this. This is why I have no plans in the immediate future to stop doing this. So moments of joy, and as important, opening the door, going out to the hall and sharing that with a colleague, or texting a group, or texting individual person. So feeling good about the work by experiencing fully those moments of joy. What would any recommendation to healthcare providers be if it didn't include, reminding us about the good health habits? I'm not going to spend a lot of time on this, but, diet, exercise, sleep, I already talked about that. Sometimes that goes unacknowledged. I've already mentioned my own experience of sleep deprivation and how I'm sure that affected my, performance. Exercise, by the way, one thing I would say is, as Americans, we're not exactly people of moderation. We're kind of an all or none society. So I think I have plenty of, I'm not one of these people, but I think I have plenty of colleagues who feel like they're not exercising if they're not spending, a couple hours a day at the gym. They're not running if they're not running marathons. So the reality is that, and this is a direct quote from the workforce report, the Surgeon General report. There are health benefits to, quotes, a 10-minute walk in the sunshine. We don't have time during the day to go for a run, but you know what? You can take the stairs. You can, go out and stand there for a few minutes if you have a break between patients or between meetings. So I guess the point here I'm making is, absolutely, diet, exercise, sleep, but don't, take advantage of any opportunities to get some steps in. I also mentioned alcohol intake here. During the pandemic, so starting in March 2020, there's been a statistically significant increase in alcohol consumption in the United States. I can tell you physicians were not protected from this increase. I'm not saying, by the way, that the prevalence of alcohol use disorder went up during COVID, but what I am saying is the intake increased, and I think in some cases has caused problems that really have gone below the radar screen. Maybe a little bit of irritability that, maybe I'm irritable anyway. The alcohol, doesn't exactly help with my fuse or my patients. And we've certainly had, a handful of physicians referred to us where alcohol really wasn't the problem, but during our assessment, what we found was that maybe alcohol wasn't really giving you the problem or causing the problem that you're coming here for. But by the way, you ought to rethink your relationship with alcohol, because it's probably not making you the best version of yourself. And then the final bullet point directed at us as individuals is, one voice can be loud, but many voices of advocacy together. Again, that thing about connection and working together, advocating together for the positive changes that we want. And, really, we know what it is that would make our lives more tolerable in the workplace. So, all of us together advocating for those things carries more weight than, me individually, you individually, that kind of thing. So those are the recommendations specifically to us as individuals. That's the extent of it. And as I said, there were recommendations made at all levels. I do want to mention just a few that were made at the level of healthcare organizations, because I'm sure most of us on this webinar today function within the context of some kind of healthcare organization, whether it's, providing direct care, being part of a physician health program, insurance, utilization management, that kind of thing. So most of us do function. And so one of the recommendations to leaders in healthcare organizations is for the leaders to themselves, despite the craziness of their schedules, really connecting with the people who are doing the work in the trenches and listening to their input and making them part of the improvement process. And I think a lot of places have kind of caught on to this, showing people how much they're valued again, over and over again. When you look at surveys, feeling undervalued is one of the things most bothersome to those of us in healthcare. Very important point, building in time for breaks so that people can connect at work. So literally creating the time and the space in the work environment so that people can connect. And, you know, again, when I think about this, I'm not thinking about, you know, setting up things before or after work. People are busy before work. They want to get home after work. So during work is when I think we need to create the space and the time. And you're sitting out there thinking, oh my God, how do we do that? I don't know what the answer is for you individually, for your healthcare system, but I think we can all be pretty creative in figuring out what works for us, for our system. And then helping physicians and other healthcare providers to rebuild a connection with the communities in which we do our work. You know, all of our hospitals, you know, we, even if they're not considered community hospitals, but more general academic hospitals, you know, we live in a place, you know, we exist in a place. It's those people who are coming into our emergency rooms. Let's do, you know, let's create the space for us to be able to understand where our patients live, you know, who the people are that are important in their communities. This is my own story of connection. It's kind of a goofy little thing, but I'll share it. So one day I was thinking of a long-term friend and colleague, actually somebody I met when I was supervising him during residency, and we've stayed close, but I realized I hadn't heard from him in a while. So I texted him, you know, and said, hey, you know, we haven't connected in a while. How you doing? You know, is everything okay? And this is a direct quote. He said, I am overworked, yet feeling like I'm not doing enough. Now, I know when I saw this, my reaction was, and by the way, I haven't explicitly written my response because it was, I don't want anybody to be offended by the off-color nature of what I said. So suffice to say, I said something like, golly gee, you feel that way. I felt that way for a long time. And then his response was, I'm glad it's not just me feeling that way. Again, you know, I don't know, this took me, 45 seconds to engage in this. And I think that this was kind of a validating experience for both of us. It's, hey, I'm not alone. I get it. I'm not the only one who feels this way. You know, I'm trying to kind of do the impossible here. You know, it's good to know other people are kind of with me in this struggle. So I think a lot of what the connection is about is us you know, being validated by each other. I want to say a little bit more about this issue of loneliness, and then talk a little bit about kind of the future and, you know, maybe things that we can do, you know, individually as a system, and then, you know, across the individual states and the United States. So I just finished really kind of talking a lot about kind of the stuff that came out of that Surgeon General report on burnout. And that was 2022. Last year, the Surgeon General convened a work group that published this report, and it's entitled "Our Epidemic of Loneliness and Isolation." Yada yada yada. And you know, this got a bit of publicity, you know, in the general press. So you may have heard about this. You may have read it. Again, I know I probably should provide a link. I didn't. But if you Google Surgeon General loneliness, it's going to be all about this report, and you can access this report. And it's just a couple of what I found to be really stark points that really impacted me. Now, maybe all of you knew these things I'm about to say. I didn't, and so they really kind of struck me. So in one of the summary points that they made in terms of the health risks, so this is physical health risk, medical, not just mental health or addiction. This is really physical health risks of loneliness. Over 4 decades of research has produced robust evidence that lacking social connection, by the way, I'm going to spare you the methodological definition of social connection, lack of social connection. Suffice to say, you know it when you see it, right? So evidence that lacking social connection, in particular, scoring high on measures of social isolation, is associated with a significantly increased risk for early death from all causes. And to underscore that point, the increased risk for all causes of mortality when you lack social connection. So the risk is worse for those people who lack social connection than for those people who smoke up to 15 cigarettes a day and drink up to 6 alcoholic drinks daily. You know, we as healthcare providers, if a patient came in and said, you know, I haven't been able to, you know, I'm not smoking as much as I did, but I can't get beyond this hurdle of like half a pack a day, we would work with them on that. And similarly, you know, if somebody came in saying, you know, I drink a 6-pack a day, we would, you know, we would bring all our powers of motivational interviewing to bear to try to, you know, to try to get them to reconsider their relationship with alcohol. And so similarly, you know, this isolation, this, you know, this lack of connection, you know, is not good for the health of the healthcare workforce. And so it goes beyond, you know, beyond drinking, beyond not taking care of our mental health. I mean, there's, you know, we need to really focus societal attention on how we take better care of healthcare providers so that the healthcare of our communities is up to where it needs to be. So just a few points of things to think about as we turn toward the future. You know, I think about, particularly as the medical director of PHS, a physician health program, you know, I think about this as, so what does PHS need to look like as we move further into the 21st century to meet the needs of the healthcare, you know, workforce. And so first point I'd make is we can't do our work as though we are an island apart, you know. And, you know, there's this culture in medicine of kind of the, or even American society of kind of the rugged individualistic thing, you know, the cowboy icon. And that's just, you know, that is such a myth. So we need to kind of get over that and really get better at collaborations. And yeah, I think that is a point that we're learning. I can tell you, you know, both as a PHP medical director and as being on the board of the Federation of State Physician Health Programs, there's a lot of collaboration going on. You know, for example, the Federation of State Medical Boards and FSPHP have worked for a very long time in destigmatizing, updating and destigmatizing the licensing and relicensing language. So now I think it's about 30 states have destigmatizing language. So when you answer the question on your medical license application, it's much less stigmatizing, much less intrusive, at least in the 30 states that have made the change. But that all, you know, that wouldn't have happened if there wasn't this, you know, real cohort of collaborators. So everybody part of the village. You know, we have to acknowledge the forces beyond the individual and the control of the individual physician contributing to why he or she behaves the way that they do, and work with other physicians rather other villages to kind of fix those problems. You know, increasingly since COVID, it's become, you know, really a challenge for particularly younger physicians who are trying to balance the demands of work and a young family. And I think that you know, as we work with these individual physicians, you know, increasingly we're kind of working with the healthcare, with the department that refers them to us. You know, are there things that can be done for these physicians? This, and related to that, increasingly we're going to be advocates. You know, we're invited into crisis situations and we help with those crises. But, you know, can we request the opportunity to give feedback that may help to avert crises in the future? Well, I'm happy to talk more about that, but I don't want to say anything more about that because I want to leave some time here. Again, I already mentioned this. You know, advocating it within systems to provide space and time outside of before work and after work for people to connect. Working with medical schools. So early on, we have a medical school advisory committee, and we're talking to the deans about how can we as a physician health program have a touch point with the students throughout the 4 years of school. And again, if you look at this report, the burnout report from the Surgeon General, they really call out all levels of society, and we can, you know, we need to roll up our sleeves, dig in, and start collaborating at all levels. Federal, state, government, you know, the people who accredit healthcare institutions, the people who accredit CME or GME programs. You know, let's cut through the kind of the red tape that we can to take some of the burden off of the healthcare system. All right, I'm going to stop. I guess I'll stop sharing.
Hi, Mark. Thank you so much. That was so much information. I think so really, really good information, solid information. I'm going to say there, I asked, you know, folks to put things in the chat, and we do have a couple comments, but I'm going to lead off by saying that I think your comments about community and staying connected are so very important. And what you say about the Massachusetts program is almost identical to what we see in Maryland. And we're getting oftentimes folks who have, yes, they have a family, a social network, but the connectedness to other people that are in the profession seems to become fractured, and it's real tough. So, oops, trying to pull my chat up here. So we do have, you know, one comment that I, you know, I think is very relevant. The reality of the burden of prior auth has increased now for imaging and basic first-line medications. Loss of physicians is not just loss of experience, it's an increased burden for those who remain. And I think, you know, definitely that whole prior auth issue has in at least, you know, in my perspective, gotten more and more problematic.
Yeah, in fact, I didn't mention this, but we here at the Medical Society, prior to my coming to PHS, again, which is part of the Medical Society, they had established a burnout task force within the Medical Society, collaboration between the Massachusetts Hospital Association, Mass Medical Society, and now PHS. I was invited to be a part of that. And not surprisingly, if not the first, I think it was the first issue that the burnout task force took on was this issue of prior authorizations, and working together, you know, within Massachusetts, and, you know, the insurers, you know, literally inviting and saying, listen, this is untenable. You know, you're losing physician providers to your network. It's not just patients are losing physicians and we as colleagues are losing colleagues and the burden's falling to us. Hey, big insurers, you're going to have challenges getting your members to see a PCP. As a result, you're going to be paying more because they're not going to go to their PCP, and now they're going to need specialty care because the diabetes is not pre-diabetes. It's now an admission for diabetic ketoacidosis and yada, yada, yada. So, that's one, I think that's one thing that we can do concretely is, again, can we develop some coalition of the right people? It's got to be a kind of a broad coalition to take on any of these things. But, we've had some success, with doing that and getting, at least some of the insurers to the table.
So we have another comment here. Can you comment on evolution of stigma self-referrals and other referrals to these programs?
Boy, that really is a big topic. I guess what I would say on stigma is that I think we've made inroads. We still have a ways to go. I think the work that we as an individual physician health program, what many of the other programs, including I'm sure Maryland, have been doing, and what the Federation of State Physician Health Programs have been focusing on. A couple things. I already mentioned the destigmatization of at the level of the boards of registration in medicine. Working with them in their Federation of State Medical Boards, to try to get the boards to adopt less stigmatizing language, so that, they're not asking, over the course of your life, have you ever, been a real mess and unable to, to take care of it? It's much more focused on, currently and importantly, are you getting help? Because I should have brought the actual language in Massachusetts, but basically, it's like, do you currently have a medical impairment? Doesn't call out, alcohol or depression or anything like that. And if you do, and you're getting help, and your condition is known, again, I wish I had this specific language, but your condition is known to the Physician Health Services, your PHP in Massachusetts, then you don't have to answer this question. Actually, you can check no further questions. So one of the fears that people had was, if I check yes, if I'm truthful on this, the bind is, if I'm not truthful, that's bad. If I'm truthful, that's also bad. So let's update the language. And so, I think at this point, most of the boards have done so. So, there's that. There's also, trying to destigmatize the credentialing. In fact, later today, I'm giving, in the room next door here at the Medical Society, I'm giving a talk to the Massachusetts Association of Medical, medical office staff on the importance of destigmatizing the credentialing questions and the re-credentialing questions, which are in many ways even more intrusive. The questions that insurers ask if they're going to impanel, a provider. So that's where, a lot of the work has been seeing. So it's first acknowledging stigma as a major reason why people are not going to get the help that they need to take care of themselves. And what can we do to lower the barriers, to decrease the stigma, lower the barriers to getting help? And so a couple of concrete ways of doing that are what I mentioned, working with the state medical boards, working with the credentialers, with the insurers, that kind of thing. I hope I answered the question, but in any case, that's.
Thank you. One more question, another question before we break. Will you say more about about giving feedback on issues beyond the individual as it applies to
Yeah,
PHP?
what I mean is, so now what I'm talking about, well, let me give you a real case. This is one I was going to mention. I won't have time for questions, and I'll finish with this. So we got a referral from a program in Massachusetts, and this was a residency program. And as part of the residency program, some of the trainees were required to go to go to collegiate sports events and take turns being the physician behind the bench in case there was a problem. And so this one guy's on, and he appropriately diagnoses that this is one woman athlete is having leg cramps because she's likely dehydrated. So he feels like, you know what, if she could get some fluids, she probably, it'll resolve the cramps. She'll probably likely be able to get back into the game. So, but so he didn't know how to start an IV. It's not part of his training, which was news to me, because when I was in training during the Stone Age, the residents were the ones who put the IVs in. There wasn't an IV service. So I had, I guess a little out of touch with what's going on in the residencies these days, but in any case, at least with medicine and surgical residencies. So he got a non-physician colleague who's used to putting in IVs to stop by, put the IV in. Player was happy, team was happy. I think they won the game. But then he gets in trouble because, he basically, it was conceived as a boundary problem. And, in the end, the guy really didn't have a boundary issue. He did need some kind of professionalism training, and everybody, loves the guy. And as far as I know, there's not been any more issues. But, again, when I was talking to the program director who made the referral, I said, wait a second, why didn't he just put the IV in? Again, I didn't know that they weren't trained to do so. And he said, oh, Mark, things have changed since you were in training. I was like, yeah, I'm sure they have. They don't do that. Now we have the IV service. I said, okay, well, I didn't know that. What's interesting is when I closed out that, case kind of without any further services other than recommendations for professionalism courses, the training director said, hey, by the way, we've decided that we needed to, make that change you suggested. Mind you, I actually didn't suggest anything. I just asked a question because I didn't know. But they took that as a recommendation to implement some basic training in IVs for the residents that they knew they were putting in a position where they might have to start one. So that's a one small kind of vignette about what I mean about feedback to beyond the individual physician. Yes, physician, you have an issue. Here's what we're going to do for you. But, listen, program or CMO, this is like the third time you've called, in the last 6 months. Maybe there's something else here, that kind of thing. So that's what I mean by that.
Thank you so much. I have to say that we do have a couple of other comments and questions in our chat, but we're at break time. So what if it would be okay with everybody we'll do is we'll break, but I'll ask Mark maybe to weigh in on some of the questions through the chat. Thank you so much. I think these are great points that you've made, Mark. It's so wonderful that you've been with us today, and thank you so much to our audience because they're asking some really great, very pertinent questions. But on this note, let's all take a break. We're going to be back at 10:10 and maybe a couple minutes later. But thanks, everybody, and see you soon.